great job putting this together. Ladies and gentlemen, I'm delighted to host this episode, a webinar that's sponsored by the Center for Healthcare Leadership and Management at the University of Texas at Dallas and part of the Jindal School of Management. Our degree program is about the business of healthcare. While we are just enamored with the clinical expertise and the discoveries that are becoming available to this generation, one of the big issues we have is the business of healthcare. We concern ourselves with the process and the systems and creating functionality for healthcare providers so that they can do the things that they do in miraculous ways. We sit today in the midst of one of the most significant healthcare crises of our history and our generation, that being the pandemic of 2020. Businesses are continuing to modify, adjust, and shift in response to this pandemic. And this webinar is intended to kind of go a little over the obvious and the apparent. I'm the director here at the center, and also have with us on this webinar three esteemed additional colleagues. Actually, I'll take that for Tim Stevens has just dropped in, but we have Professor Daniel Karnuta, we have Professor Don Taylor, and Dr. Jim Walton, and also Dr. Tim Stevens. We're going to navigate through some thorny questions. On our previous webinar, we've asked, how are hospitals operating and functioning? What have they done prior to this pandemic that makes it such a vague and curiously difficult terrain to navigate? We've also hosted a webinar that used the expertise of Dan Karnuta. Professor Karnuta is on the faculty here, but prior to joining our faculty, was the CFO for Karnuta Health, one of the largest revenue cycle companies for healthcare in the world. And so he gave us perspective and also some insights on the most recent supplemental $2 trillion legislative package to hopefully stem some of the disasters that we have. Well, today we're delighted to have Jim Walton. Jim is a physician that is sold his soul and has gone into administration. And I've known Jim for decades, one of the finest people I know, and also a tremendous leader in the industry. He also teaches classes here at UTD, both in the undergraduate and the graduate level. And what I found exciting for me is to have him teach a class on the introduction of business and see his classes fill with pre-med students. Nothing could be more inspiring to see physicians and aspiring physicians kind of get it and understand the business side of the equation. I'm also just noticed that Dr. Keith Thurgood has joined our group. He also is part of the talent here. Dr. Thurgood is a retired two-star general with the Army. Army has tremendous experience in supply chain and phenomenal experience on the business side as well. So having said all that and made in the introductions, we're going to take some time with Jim Walton today. Dr. Walton, we're just delighted to have you here. What I'll do is I'll moderate this panel and invite some of our faculty to comment. Faculty, if you have a burning issue and we're not getting to you, just, raise a voice and we'll jump in. But Jim, thank you for joining us. If you wouldn't mind, tell us a little bit about your current role and responsibility, sure, and then we'll jump into the discussion.
Yeah, thank you, Britt. It's a pleasure to be with y'all today. My current role is I'm a CEO of a large independent practice association or physician association. It's abbreviated called IPAs. And we have 800 different medical practices across North Texas with 1,500 different physicians and 200 mid-level providers as members. When you look at our physician population, we have 1,000 specialists and covering about 50 different specialties and 500 primary care doctors in both the adult and pediatric populations that are covered. Our company is about 35 years old. It's been around for quite a long time. I've been the CEO for the last 7 years. I was hired, replaced the retiring CEO that was a non-physician, and the board of I have 13 bosses. They're all doctors. It's a board of directors. And we created a second company in a joint venture with an organization called Innovista Health Solutions out of Chicago to build an accountable care organization that encompasses 300 of our primary care physicians. Our second company that I'm also the CEO of has relationships with 12 different health insurers, including Medicare, CMS, Medicare, Medicare Advantage, and commercial payers, as well as Medicaid, covering about 80,000 different patients, both pediatrics and adults. So I have a very big space to work in. Our general model has been focused on the actual practice of physicians. Our average practice size is about 1.8 physicians per practice, with probably a mid-level sprinkled in between them. So they're very small. You would call this small businesses. You would call these small business entrepreneurs, and you would be spot on. These doctors are radically independent. They're really autonomous. They've chosen not to be employed. Some of them have been employed and come out of employment and find that they are better suited to be their own bosses, if you will. And so that's kind of the context that I work in. My history was I was inside of a large healthcare system called Baylor. Baylor Healthcare System is now Baylor Scott & White, for about 20 years, focused on community medicine and health disparities is what I did for Baylor for about 20 years, developing primary care delivery solutions and specialty solutions for the medically underserved population. And that's kind of where I ran into Britt.
You know, the breadth of your experience and the depth of your knowledge is important for this conversation. So, Jim, thank you. Thank you. We're delighted to have you here. Now, question that we pose to you is, in light of the pandemic, what's been the impact? And I'll jump in on a regular basis so we can move the conversation along. If you have comments or questions, I'm speaking to those that are participating in this webinar. We have a chat function, so just shoot me a note and we'll see if we can get through those and really drive some good conversation. Yeah. Jim, tell us a little bit about the impact of the pandemic on the people you're working with.
And I viewed the previous two webinars and would agree that we're living in a moment that would be like 100-year event. Now we have to recognize that in the course of my 38-year career in medicine as a physician, frontline physician, and now as an executive, obviously we have never seen anything like this, but it doesn't mean we're not going to see something like this again. If you go back and look at history, and a lot of the students on the webinar here would recognize that reading and understanding history of the world should tell us that this really is not an unusual moment. It's just as that we've never had it before, but it recurs over and over and over again, which we would consider as a pandemic or a viral or bacterial epidemic, pandemic. We've seen it before in the course of history. It's this intersection, though, that we're seeing today of an advanced economy of the United States being struck by a pandemic that was, and the system was poorly prepared for what happened. It wasn't that it wasn't known that it could happen. It wasn't known that how you might prepare for this. It was a conscious decision along a series of time to not prepare to scale a solution because of the economic reality of what that scale would look like. If you go back to look at 9/11 and think about what was the response post 9/11 in the public health sector, what we started to see is what you would consider as a pre-positioning of assets where potential risks would be with hurricanes and earthquakes and things like that, where you would see one state or one region injured. But what we're seeing in this model is we're seeing almost a universal strike across a large swath of Americans' metropolitan areas. So I can speak to this with regards to what is happening on the ground, and then I can back up and kind of give you some context of what I consider would be the why. The independent physicians are independent. They're practicing without a net, you would argue. They're not employed. They don't have an employer net. That means their salaries are based upon how many people they see and how much the insurance they bill and how good they are at their business, how they manage their expenses, how do they send out bills and receive those bills, and then how they spend their income and how much money that they take home at the end of the day.
Okay.
That volume 3 weeks ago was normal, or 4 weeks ago now was normal. They had normal volumes. The week of in Dallas-Fort Worth, when we had our Dallas County judge basically tell everybody to stay home, they had a 50% drop in volume coming through the doors. The next week, they had almost a 90% drop in volume, when all elective procedures were stopped, essentially, for specialists, for proceduralists, and all we call cognitive specialties, which would be primary care and other specialties where they don't do particularly a lot of procedures or interventions. They do most diagnostic work. That basically fell apart, and they began to replace that with telehealth. So many physicians were able to pivot very, very quickly to replace the volume of, let's say, 50% of their daily time with telehealth in the first week. And now one could argue they're up to 75%. So that'd be some rough averages. So where we're standing today is we have doctors that are basically running their businesses through a telehealth channel that are probably at about a 50 to 75% capacity.
Let's have Dan Karnuta jump in here. You got a question, Dan, or a comment?
Yeah, Jim, before you leave that topic, how were you able to pivot, or were those practices able to pivot so quickly to telehealth? Do you have a CIO or an IT organization it's centralized under your command, or is there a decentralized IT environment that you have?
So IPAs exist. The core functions of IPAs has been to basically protect the business functions and to perform some of the core business functions for doctors to obtain a relationship with the payer, be credentialed and re-credentialed so that they're of high quality, and then focus on operational issues that they need. We're a micro example of the larger organization that we would call the Texas Medical Association, or the Association of Physicians across the state, which is about 55,000 doctors across the state of Texas are members of TMA, Texas Medical Association. So you could argue a little bit like we're the little platoon, if you will, and I'm going to, where's
Dr. Thurgood, yeah,
Dr. Thurgood can talk about this as far as the logistics, but we're the small regional platoon or battalion of a larger state issue. So doctors, when they were pivoting, when they saw that drop and they had that kind of moment where they realized in that week that they said, my business has just been hit based on these stay-at-home orders, they pivoted to either our organization at the local level or up to the state to say, how do we pivot into telehealth? Now, the great news is the technology was available, and it's just extraordinary how you did not have to do anything different with your core electronic medical record. This actually stood outside, so you had no integration issues, and you could actually function with a bi-directional communication, both audio and video, with the patient, with a new software that was effectively free or almost free for the physicians to stand up. Literally 5 to 10 minutes is what it takes to learn how to use this for both the patient and the doctor.
I talked to the CEO of a hospital in the Midwest, and he said they had intended with their integrated delivery system to move this forward, telehealth, and they anticipated a 9-month integration period, that it would take them 9 months to convince everyone to embrace this. He said they stood it up in 5 days.
Oh yeah.
So it's accelerated innovation that is inspiring. Dan?
So a follow-up then would be, what about medical records? Okay, are these guys practicing from home now, or are they in their offices?
Yeah.
And if they're in their offices, I assume they don't have the same administrative staff they did. They probably furloughed them. So what are they doing? Are they writing these telehealth visits on paper now, or are they able to do it electronically? What's happening?
So we have doctors both still on paper. I know that sounds strange, but we do have doctors still using paper charts, and but the vast majority of them on cloud-based EMRs, and so they can portal in from anywhere, right? So the most advanced physicians, I would say that represents about 75% of my network, is advanced enough where they're in a cloud-based EMR, so they can actually do the visit. We could be having a visit right now, and then I could just toggle over into my EMR and basically catch your note up. Interestingly, they're also using their staff working remotely. They can pre-check the patient in. So what would happen, you could actually create a calendar, a schedule. The staff person will reach out to you and collect your information, putting that in the medical record prior to, let's say 30 minutes prior to the visit with the doctor. So that's the method, how it's working.
But one thing I'd note is, while you say that volume is returned to 70% of what it was previously, I'm guessing that is not the same amount of revenue.
Let me give you, let me speak to that. This is vitally important for the students in the call. The tragedy of it all, if you're in private practice, is that you have a business model that is structured where you have probably a 50 to 60, if you're good, you're at 50, if you're a primary care doctor. If you're not so good, you may be at 65% overhead. That includes your insurance, your health insurance, for how rich your insurance benefits are to your employees, to all the way down to what type of support services you use and how well you've struck those deals. Do you have group purchasing opportunities where you're getting discounts? Obviously, in our association of 1,500, that's one of the benefits we provide members, is we can have a big group purchasing, not quite like HCA's or Walmart, as far as group purchasing, but we can give doctors better discounts than they can get by themselves.
Okay.
So that point is that, and I'm just going to give you a number. The average primary care doctor, let's just ballpark it, would probably be able to get $150 reimbursed per visit, and they might do 20 to 30 visits a day. Just do the math. That's what's in normal state. In the telehealth state, they're going to get $75 per visit, and they're going to drop that volume down. So not only are they going to get a hit on the rate, but they're going to get a hit on the volume. So they're taking a 50% shave on the rate. They're being reimbursed for the moment, and they're also volume is cut because they just can't process that speed.
And also the ancillary. So you won't have laboratory, X-ray.
That's where, and Britt, you're bringing up a good point. That's the delta. It's not they're actually, the payer is actually paying at par as if it's a face-to-face.
Oh, got it.
The delta between what I would have made versus what I'm making today is the ancillary revenue.
Got it.
So what's happened is physicians are basically recognizing that they're at a 40 to 50% of what they were making 3 weeks ago. Think about that for just a second. And so they're immediately looking at expenses all over the board and saying, how do I survive? And then, Dan, you spoke to this with regard to this CARES relief, right? Where doctors, businesses can stand in line at the bank window and get their share of 90 days of salaries to protect salaries. The other thing that you spoke to in one of your previous notes that I wanted to make a special note of is when hospitals were carved out to give a special $100 billion, $150 billion of the CARES Act was set aside for hospitals, there was nothing set aside like that for physicians. And so if you're a physician in an employed hospital relationship, and a hospital now can go draw down additionally $150 billion, some of the $150 billion, some of that will naturally flow to support the salaries of the doctors who are literally idled. So the hospitals have a huge problem because they're sitting there with these very, very expensive cardiologists and orthopedist employees that are basically not doing elective work, that are basically very expensive to pay every 2 weeks to keep them keep their salaries. So what we're starting to hear and see amongst the employed doctors, whether or not they're employed at hospitals or employed within private equity supported organizations or insurance owned organizations, is that some of them are not protected. If you happen to be an anesthesiologist that supported a bunch of elective surgery, you could be asked to take a pay cut by your employer, just like any other employee, which is an unprecedented moment in American medicine. If you think about it, this is, again, it rivals from a challenge of the disease of the COVID virus and how it attacks the body and kills in its efficiency of killing vulnerable people. It has, in effect, in the business side for physicians, it has the same effectiveness of attack, infect, and kill very vulnerable physician practices.
That's a very interesting analogy on the impact. So I'm going to ask my colleagues to jump in here with a question or comment. Just raise your hand and I'll call on you. But to that end, we've got a dynamic within healthcare that's of concern. Dr. Thurgood has a comment, and then Professor Taylor, I'll jump to you as well.
Yeah, first off, thanks, Jim, for spending some time with us and our students today. When I think about the impact of less revenue, less visits, it's massive, as you already mentioned, in big hospital systems. In Texas, though, we have a lot of rural hospitals, and they are particularly impacted by census count and revenue, et cetera. And there was an article today that estimated that a quarter of rural hospitals might actually go under without some kind of assistance that you've been talking about. Do you have a point of view on that, or?
Yeah,
as it relates to physician. Yeah, within physicians' practices, right?
Yeah.
That's right. You're asking?
Yes, that's right.
So thanks, Keith. So my early part of my career, you might not remember, I was a internist in Waxahachie, Texas, which would be considered, as soon as you drive south on your way to Waco, as soon as you get out of the city, the next town you're going to run into is Waxahachie, which would be considered a rural hospital, it was about 40 beds. We had a 4-bed ICU, and that's where I started my practice. So in those markets, my experience with those markets is, number one, the one thing that they don't do in rural hospitals is they don't employ doctors. They have a tendency to have the traditional relationship with their physicians that has been there for as long as I've been around, which is that doctors have admitting privileges to send their patients to the hospital when they're sick, and those doctors have an obligation to service the hospital emergency room or delivery room when they're on call, when it's their turn to be on call. So for example, there were 5 internists when I was in practice in Waxahachie, and we would rotate every 5th night to cover the emergency room and take ICU admissions or any admissions. My wife was one of 2 pediatricians. She was sharing OB call, if you will, or neonatal call every other night. So those practices, as you might guess, to the extent that the community is locked down, right, that the community of patients is actually adhering to the county judge of that community, or in our case, the state governor who just recently came through and suggested everybody stay in place, they'll experience a fairly big drop in elective work. And in fact, there was an article in the New York Times today with regards to how much the reduction in heart failures and heart attacks and strokes have gone down as well. and they can't figure out, they can't explain why the incidence rates of these acute illnesses actually is going down during this epidemic. So not only so what we're seeing is we're seeing less acute illnesses pop up, and we're seeing obviously a lot less elective work come in through the doctor's office into the hospital emergency room. I've heard from ER doctors that like at HCA, where Britt was practicing just 2 weeks ago, Britt, HCA Medical City was quoting a 50% reduction in their ER visits in a major metropolitan area. The same.
Well, nationally, they're saying that their volume is down 50%,
yeah,
and 40 to 50% on the inpatient side. So not only here in the DFW, but nationwide now, HCA knows how to run hospitals, and they have collective wisdom. But let's get back to Keith's question, because let's see if we can pin him down. What do you think, folks? We have a bunch of private practice physicians. Do you think they're at risk of closure or consolidation or relocation because they just can't make it in the rural environment in light of this?
I'm not sure where they would relocate to. It's terrible everywhere, right?
They're going to Waxahachie.
Yeah, but the reality is yes, there is this vulnerable subset of the population of independent physicians and employed physicians. I would argue I'm going to be bold here.
Please.
There's going to be a backlash, a serious backlash from physicians after this comes out. Some of it is with regard to how much personal exposure of their own personal life that they took when they were doing ICU care and ER care. So a subset of the population of doctors who's really on the front lines certainly is really the tip of the iceberg of all the physicians. That is to say,
well,
but the backlash is going to be extraordinarily important with regards to what doctors say. That's number one. Number two, there's going to be a subset of doctors that are going to go out of business. They're going to shut their doors, and the patients are going to have to find new doctors because they really weren't good business people. They didn't really run their businesses very well. So that's just like rural hospitals. That is, not every hospital in America is well managed and well run. So there's going to be some opportunity for consolidation there. But the bigger group in the middle is what I want to talk about. So the bigger group in the middle is going to start to approach the payer community. Not only is telehealth here to say, but I think the other thing that we're going to see in a very important way is we're going to see doctors accepting something that the insurance companies have been wanting to do for a long, long time, but have had a lot of resistance to have done, which is a little bit like what we call the physician population bearing financial risk or bearing professional financial risk, being paid a per member per month fee for every patient that they take care of or that's assigned to them, so that that's the amount of money that they're going to get for all the patients that they take care of every month. We call that a prospective payment strategy. That prospective payment gives that doctor a predictable level of income, but they then are accountable to taking care of that population of people for the entire year. And so if they don't see them at all, they do all the work by telehealth, then terrific. If their patients happen to not be cared for very well and they get sick a lot, that's going to be a problem for those doctors.
Do you think the pandemic is going to accelerate that shift from fee for service to prospective payment?
There's a cry right now from physicians, independent physicians. They're crying out for that. Whereas before it was like, no, we're in love with fee for service and we're never going to come off. It's like being addicted to crack. The doctors were just pushing, especially independent doctors in Texas. Now, in other markets, Boston, California, Minnesota, there's been plenty of markets in the country that have demonstrated prospective payment works very effectively, and we've been promoting that from our organization for our physicians. That's what really the accountable care organization is designed for, in order to prepare independent doctors and hospital-based doctors to do well with prospective payment, because basically you're living within a global budget.
Don Taylor, you had a question or a comment,
Sure. And I'd like to focus on the physician group practice individually. You've just described a lot of anxiety and uncertainty amongst not only individual revenue and revenue generation, but practice viability, as well as treatment protocols, and a lot of uncertainty in the treatment protocols and potential clinic exposures of patients or staff exposures of patients. A lot of uncertainty in the space. My question is, back in my old life in Air Force medicine, we had incident management, we had plans, we had books we pulled off the shelf and checklists where we assured communication and reliable trust. This is where your culture plays a lot into how you manage that anxiety in the space and how you kind of align everybody's point of view and purpose to collectively move along a path that you want. My question to you is, how are you managing that communication and how are you managing the culture in this space?
I love the question, Don. Thank you for that. There was an article in the New York Times by a General Stanley McChrystal that some of you may have read before. He wrote a leadership book called Team of Teams. I would recommend it to the students if you're interested in leadership. But anyway, about 3 weeks ago, he wrote an editorial in the New York Times about what we learned in leadership from 9/11 and some leadership principles. And I read his book several years ago, and I gave it to my management team at Genesis, which, let's say my senior management team is 6 folks. And then my larger management team, my junior management team, is probably 13. So immediately within the last 3 weeks, we created, you'll find this amazing. We went on a war footing, if you were to call it, but just use the metaphor. We went on a war footing. We have daily 8:30 to 9:30 meetings with 13 people. We're doing what we're doing here today. It's all visual on a screen. And we're basically taking a vision of saying, maintaining independent physician practice viability or survivability. So again, follow the war metaphor. We're just trying to save our soldiers. Number 2, we suspended the thought for just as long as we can that we're in a business as usual standpoint with doctors out in the outpatient setting. Just no different than a hospital would do. What y'all were talking about a few webinars ago, that's what a hospital would do. We did the same thing with independent physicians. And then we started churning out content on a weekly basis. On Friday, my chief medical officer, under her heading, sends out what you need to know this week to 1,500 doctors and 200 advanced practice physician providers. So on every week since, let's say the last 3 weeks. And what we're doing now is creating innovation around, so we're spreading innovation. So for example, the software doxy.me, which is you portal in, and that's how you do telehealth. And you can do two-way telehealth literally within 5 or 10 minutes of starting your work. How to code for that so you can get billed for that. How to do COVID testing. How do you do community-based COVID testing? How do you find PPE if you're an outpatient doctor because all the PPE's been pulled into the hospitals? How do you do safe visits?
Right.
On and on and on. So That's what we're working on.
Don, you got to unmute there for a sec. He raises an excellent point as it relates to the dynamics within a small business. To that end, we're coming towards the end of this conversation. One question that was raised on the chat was about confidentiality. We're in new waters. We're talking about new and dynamic and innovative ideas.
Yeah.
You suggest we'll see more telemedicine, we'll see consolidation, we'll see physicians that will have to step away from the profession. What other dynamics do you anticipate into the future?
Well, as you know, maybe you don't know, but there's been some suspension of the HIPAA rules during this crisis.
I did not know that.
Okay, especially as it comes to telehealth. So there's been more of a liberation of technology that you can use. I can use, for example, a FaceTime to do with my phone to do a telehealth visit and not have to worry. We can do e-consults through email now without worrying about HIPAA. So when I talk about a backlash, I think what we're going to see is medicine organized to talk through some of the regulatory burden that has been on side, that has been thwarting, if you will, the development and advancement of these things. Like, here's a great example: remote patient monitoring with both wearables that you put on your body and peripherals, like your Bluetooth scales and Bluetooth diabetes checks and blood pressure cuffs and things like that. That's going to be an enormous industry. We, the physician community, are going to actually we're creating, for example, we call a virtual on-call specialty network to co-manage through telehealth remote patient and using remote patient monitoring. So doctors, maybe 2 doctors can get on a telehealth visit at the same time with a patient at their home, and deploy the proper remote patient monitoring so that the patient doesn't have to never travel for care. When you mirror that opportunity, so you got to have regulatory relief mirrored with remote patient monitoring and telehealth with this bubble of Medicare population that's just enormously, the baby boomers, people over 85 that are going to be less mobile. There's going to be more of these people that are less mobile. There's going to be a huge business opportunity for physicians to kind of not only get into the space, but really to own the space or to control the space where before they had given that up. And I think the backlash is doctors, some of the doctors are going to say, look, this didn't really work out for me to be an employed physician within a large PE-backed or venture-backed organization or within a hospital system. Some of them are going to find themselves in those employment relationships because they just can't hack it running their business, running their own business. And then finally, we're going to see a consolidation of independent doctors into larger groups so that they can have purchasing power, more of this responsiveness that Don's talking about, organizational responsiveness.
You know, the information he provides just concerning, but illuminating. What I'm going to do is I'm going to ask each of the faculty members to give a very brief takeaway from today's podcast. Very brief. I'm going to start with Dr. Thurgood, Tim, Dr. Stevens, then Dr. Taylor, Professor Karnuta, and then Jim will let you have the final word on that. So, Keith, summary or comment or observation?
I think one thing that is really important that Jim brought out is the impact of patient census on the actual revenue stream of physicians groups, and the healthcare system at large. I mean, these are long-term implications that it's going to take a while to recover from. And so I think it's very important that our students understand that, and that we do everything we can as healthcare leaders, not only to drive cost out of the system, but help with this transition as we start to crank the economy back up again.
Good one. Dr. Stevens?
Well, you might know that I teach the EMR class here at UTD. And it's fascinating that even with our class, we're able to access everything very, very remotely. And I was kind of surprised. We had a class last night with the UT Southwestern folks, and nobody ever missed a step. So yeah, I like the idea where we've come to a point where in the course of about 3 weeks, we've been able to make just an enormous amount of change that we've all been wanting to make with some of the barriers that are quite frankly gone. But one of the things that we can't miss out of all of this too is the bottom line is it'll be an interesting study to see how our patient outcomes continue through if there's any significant difference between a telehealth outcome as opposed to a face-to-face. And so yeah, that'll be the interesting, that might be a good study opportunity for some students later on.
Don Taylor, Professor.
Sure, just real quick, you know, I believe what we're seeing here is a compelling need to have not only the culture but an organizational governance that sets the stage for uncertainty and preparedness and risk mitigation and risk management.
Very insightful. Professor Karnuta.
I would just ask folks to take away what Jim said, that these doctors' practices, these are small businesses, nothing more, nothing less. They have to be businessmen. So you guys thinking about going into medicine, med school, or someday to manage physician practices, you have to know business. You have to know the balance sheet. You have to know cash flow. That's what this is.
Thank you. Jim, you have the last word.
Yeah, I think it's important for the students to recognize that 19 to 20% of the GDP is healthcare, and we've seen an amazing reduction. I told my students yesterday that basically the COVID epidemic and the disease burden, and it's how busy the hospitals are, is not going to make up for all the lost electives. So we're probably going to see a fall in 2020 in the total amount of spending in the United States on healthcare. The second thing is the question we should ask ourselves then is, do we really need all that spending for our economy's sake? And how do we pivot away from the dependency on healthcare as an engine for employment if indeed all that elective work kind of stops and the pent-up demand that we think is happening doesn't ever come back? I think we just think about it as a more of an intellectual exercise. But the last thing I'll leave you with this is that the American healthcare system has started and still continues with this notion that there is an option for private practice, that the choice of going into medicine to become a doctor and to go through medical school and residency in order to take your own control of your own destiny, rather than take orders from somebody else, has always been something treasured in the profession of medicine. It's not for everybody, but it's for a certain subset, and it's 30 to 40% of the population of doctors today. So the problem is practicing, running your own business, as Dan was alluding to, has become a hell of a lot harder. And there's no way you could be a great doctor at times and also be a great business person. So then that forces you into natural consolidations and different models. So something to think about as we see the output and the outcomes of this big pandemic.
Dr. Walton, we can't thank you enough. You provided insight and perspective and kind of a behind the scenes view of what's happening during this pandemic. Our intent is to be illustrative, to open some eyes. We recognize that there is a business of healthcare, and that one question that was asked in the chat, does this mean technology and all this innovation will marginalize and minimize the care and the touch and the personal one-on? And I think I firmly stand on, we need innovation in healthcare, but we will never get care out of health. So we'll continue to take care of those that are in desperate need of our assistance and support. And those of us on the business side will be behind the scenes orchestrating that care. I'm Dr. Britt Berrett. I'm the director of the Center for Healthcare Leadership and Management at the Jindal School of Management at the University of Texas at Dallas. We're delighted to host this webinar. We are thankful for Dr. Jim Walton for his participation, CEO of Genesis Physician Group, and my other esteemed colleagues. With that, we call it a conclusion to this afternoon's webinar. Thank you for joining us.